Hello everybody. Today I'm going to tell you something about sepsis. What is sepsis? Sepsis is severe infection is not only a common cause of admission to intensive care units but also the most common complication suffered by critically ill patients. Nosocomial or hospital acquired infections result in significant mortality and morbidity. Nosocomial infections have been reported to affect approximately 2 million people per year. What is the definition of infection? The invasion and multiplication of microorganisms such as bacteria, virus, and parasites are not normally present within the body, means the multiplication of microorganisms. An infection may cause no symptoms, may be clinical, be subclinical, or may cause symptoms like clinically, which is clinically apparent. An infection may remain localized or it may spread through the blood or lymphatic vessels to become systemic. Microorganisms that live naturally in the body are the causative factors. What is the definition of inflammation? The inflammatory response is an extremely sorry. The inflammatory response is an extremely complicated process that is triggered by a physical, chemical, or infection insults to the host. The presumed role of the inflammatory response is to protect the host from the damaging effect of the insult. So, by definition of infection and inflammation, it is very much clear to us that what is sepsis. All clinical definitions are also there. We should think about this. Also, the relationship between inflammation is following points. Yes. The condition characterized by the signs of systemic illness like fever and leukocytosis is called the systemic inflammatory response syndrome, SIRS. When SIRS is the result of an infection, the condition is called sepsis. Severe sepsis exists when these features are associated with organ dysfunction. The term multiple organ dysfunction syndrome has been included in this. So, what is the new sepsis definition? Sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infections. Organ dysfunction can be identified as an acute change in the total SOFA score is 2 points consequent to the infection. So, this is the new definition of the sepsis. It is defined as a life-threatening organ dysfunction. So, one must be very much clear about it. In our ICU setups, we are daily dealing with the patients who are suffering from sepsis. What is SOFA? Sequential Organ Failure Assessment. This is scoring system which was devised in 1994 to describe the degree of organ dysfunction in sepsis. The system scores the function of 6 different organ systems. I am going to tell you all those: respiratory system, cardiovascular system, central nervous system, coagulation, hepatic, and renal. So, in case SOFA, there are 6 different organ systems which we have already read, as that is respiratory, cardiovascular, central nervous, coagulation, hepatic, and renal. So, now about respiratory system, PaO2 oblique FiO2 MFG PAQ is the SOFA score. This we are going to read. If it is more than 400, then the SOFA score is 0. Is less than 400 plus 1. Less than 300 is plus 2. Less than 200 plus 3. More than 100 is plus 4. इनके CNS सिस्टम ग्लासगो कोमा स्केल हम लोग देखते हैं इसमें सोफा स्कोरिंग में 15, 13 से 14, 10 से 12, 6 से 9, तो 0, 1, 2, 3, 4 इसके अंदर भी सिस्टम बनता है. इनके कार्डियोवास्कुलर सिस्टम in case cardiovascular system, MAP is more than 70 mmHg, MAP less than 70 mmHg is plus 1, and dopamine less than 5, and dopamine more than 5, and dopamine more than 15. This URI score is, we're not going to details about these things, but this is the system which we are following. In case liver, how do we score the SOFA score? So if it's less than 1.2, the score is 0. If it is 1.2 to 1.9, bilirubin level is +1. When it is 2.0 to 5.9 is +2. 0 to 11.9, the score is +3, and more than 12, then the score is +4. Okay. In case coagulation, platelet score हम लोग देखें SOFA scoring में. If it is more than 150, then the score is 0. If it is more than 150, then the score is +1. Less than 100, then the score is +2. And if it is less than 50, then it is +3. And it is less than 20, then the score is +4. So in case kidneys, creatinine milligram per deciliter, micromole per liter. If it is less than 1.2, the score is 0. If it is 1.2 to 1.9, then the score is +1. If the score is 2.0 to 3.4, then the score is +2. 3.5 to 4.9, the score is +3. If it is more than 5.0 creatinine level, then it is +4. Now, something about quick SOFA score. If the low blood pressure less than 100 mmHg, SOFA score is 1. High respiratory rate, the score is 1. Altered mental mentation, Glasgow Coma scale less than 4, then it is 1. The quick SOFA score was introduced in February 2016 as a simplified version of the SOFA score as an initial way to identify the patients at higher risk for poor outcome with an infection. So the score ranges from 1 to 3. The presence of 2 or more SOFA points near the onset of infection was associated with a greater risk of death or prolonged intensive care unit stay. So the SOFA score was introduced in 2015, and the score ranges from 1 to 3. Okay. Now this is the one of the chart in which we are seeing that infection, bacteremia, fungemia, viremia, and parasitemia. What is cysts, in case cysts, other trauma, burns, and pancreatitis. This is easily managed by you. Okay. So now the diagnostic criteria for the systemic and inflammatory responses syndrome says the diagnosis of SIRS requires at least 2 of the following: temperature more than 38 degrees Celsius or less than 36 degrees Celsius, heart rate more than 90 beats per minute, a respiratory rate more than 20 beats per minute, or arterial PSO2 less than 32 mmHg. WC count is more than 12,000 or less than 4,000. Okay, so this is the diagnostic criteria of SIRS. Heart rate, temperature, respiratory system, this were judged by that, and WC count is more than 12,000 or less than 4,000. Diagnostic criteria for sepsis is infection documented or suspected in some of the following: general variables, fever, hypothermia, heart rate. Fever, core temperature is more than 30 degrees Celsius. Hypothermia is when less than 36 degrees Celsius. Heart rate is more than 90 means tachycardia. Tachypnea, altered mental status, significant edema. Hyperglycemia, when the plasma glucose is more than 120 mg in the absence of diabetes. So these are some of the diagnostic criteria which we are using in our daily ICU practice, like fever, heart rate, hypothermia, tachypnea, altered mental status, and hyperglycemia. Okay. So diagnostic of sepsis contains menu organ dysfunction variables: arterial hypoxemia when this PO2 by FOO2 is less than 300, acute oliguria when urine output is less than 0.5 mg per kg/h, serum creatinine increase more than 0.5 mg per deciliter over normal reading, coagulation abnormalities, ileus means absent bowel sounds, Thrombocytopenia when the platelet count is less than 1 lakh. Hyperbilirubinemia when the plasma bilirubin is more than 4 milligram per deciliter or 70 millimole per liter. So these are the diagnostic criteria in which arterial hypoxemia, oliguria, serum creatinine level, coagulation abnormality, absent bowel sounds, and hyperbilirubinemia by which we can diagnose. Tissue perfusion variables in which hyperlactemia is pathological state in which resting blood lactate concentration is abnormally high. Moderate to severe hyperlactemia more than 3.0 to more than 5.0 millimole per liter is associated with abnormal accumulation of hydrogen ions and resulting tendency to acidosis, decreased capillary filling. So what is the pathophysiology of SARS? SIRS. Mild systemic inflammatory response to an injury, infection, or other bodily insult may normally have salutary effects. However, a marked or prolonged response such as that associated with severe infection is often deleterious and can result in widespread organ dysfunction. Although gram-negative organisms accounts for most of the cases of infection related to SIRS, many other infection agents are capable of inducing the same syndrome. These organisms either elaborate toxin or stimulate release of substance that trigger in response. The central mechanism in initiating SIRS appears to be the abnormal secretion of cytokines. This low molecular weight peptides and glycoproteins functions as an intercellular mediators, regulating such biological process and as local and systemic immune response, inflammation, wound healing, and hematopoiesis. The most important cytokines released during SIRS are the interleukin-6, adrenomedulin, soluble CD, the adhesion molecules ELA1, ELAM1, macrophage inflammatory protein, 1-alpha extracellular phospholipase A2, and C-reactive protein. The resulting inflammatory response includes release of potentially harmful phospholipids, attraction of neutrophils, and activation of the complement kinin and coagulation cascade. Attraction and activation of neutrophil release a variety of protease and free radicals compounds that damage the vascular endothelium. Activation of monocytes cause them to express increased amount of the tissue factor, which in turn can activate both intrinsic and extrinsic coagulation cascade. Infection in ICU. Infections are a leading cause of death in ICUs. Serious infections may be community spread or subsequent to hospital admission for an untreated illness. The term nosocomial infection describes hospital-acquired infections that develop at least 40 hours following admission. The reported incidence of nosocomial infections in ICU patients has ranged between 10% to 50%. But with the recent attention to aseptic placement of central venous catheters and earlier removal of the bladder catheters, that incidence of bloodstream infections has markedly declined. So, risk factors for nosocomial infections. Actually, by definition, it is very much clear to us that they develop at 48 hours following admission. Risk factors for nosocomial infections are advanced age, when the age group is more than 70 years, malnutrition, drug therapy like corticosteroid therapy or chemotherapy, loss of integrity of mucosal and skin barriers, underlying disease, and prolonged use of invasive device, respiratory failure, kidney failure, head trauma. So there are multiple risk factors for nosocomial infections, including age, malnutrition, integrity of the mucosal injury, underlying disease, kidney failure, respiratory failure, and head trauma. Burns involving more than 40% of the body, topical antibiotics delay, but not to prevent wound infection. after burns, early removal of the necrotic tissue followed by the skin grafting and wound closure appears to reverse immunological defects and reduce the infections. Source and types of bacteria. Most nosocomial infections arise from the patient's induced bacterial flora. Furthermore, many critical ill patients eventually become colonized with resistant bacterial strains. Gram-negative bacteria is 30 to 60%. Source. Gram-positive bacteria is 25 to 50%. Fungi is 2 to 10%. And cultures positive in only 30 to 40% of the septic shock patients. E. coli, Staphylococcus, Pseudomonas, Streptococcus, Enterococcus, Enterobacter, Klebsiella are the source of infection for the bacteria. Common side effects. What are the common side effects? Is infection of the urinary tract. It accounts about 35 to 40%. Wound infections accounts about 25 to 30. Ventricular associated pneumonia are problem in the ICU and accounts for 20 to 25% cases. We are already treating such kind of patients in our clinical setup. You should come and see the ICU patients in which the ventilator associated pneumonia are the problems in the ICUs 20 to 25%. Intravascular catheter related infections accounts for 5 to 10%. Urinary infection. Urosepsis is a term used to describe a type of sepsis that is caused by an infection in the urinary tract. It is typically associated with the unraveling catheters or the urinary obstruction. Urosepsis is a serious complication of urinary tract infection that requires immediate medical care to avoid possible life-threatening events. Okay, so now respiratory system. Nosocomial pneumonia are usually caused by gram-negative organism. Gastrointestinal bacteria overgrowth with the translocation into the portal circulation and returns to colonization of the upper airway from the gastrointestinal tract as a result of aspiration as possible mechanisms of entry for this bacteria. Preservation of gastric acidity inhibits overgrowth of the gram-negative organisms in the stomach and the subsequent migration into the oropharynx. So, tracheal intubation may not provide effective protection because patients commonly aspirate gastric fluid containing bacteria despite properly functioning cough. Nebulizers and humidifiers can also source of infection. So, selective decontamination of the gut with non-absorbable antibiotics may reduce the incidence of infection that does not change outcome. Elevation of the head in the bed is more than 30 degrees reduce the likelihood of ventilator associated pneumonia. So, elevating the head of the bed more than 30 degrees reduce the chances of sepsis in the patients associated pneumonia. Enteral nutrition will reduce the bacterial translocation across the gut and reduce the likelihood of sepsis. Enteral nutrition. Okay. Wound infections. Wound are commonly source of sepsis in post-operative and trauma patients. Restricting antibiotic prophylaxis to the immediate pre-operative time appears to decrease the incidence of post-operative infections in some of the groups of patients. Although more commonly seen in post-operative patients, intra-abdominal infections can due to perforated ulcers, diverticulitis, appendicitis, and cholestasis can also develop in critically ill patients. So there are some conditions or some of the disease which occurs in case of severe and critically ill patients like diverticulitis, appendicitis, cholestasis. Okay, so intravascular conversion sites, subclavian, jugular, and femoral central venous catheterization are associated with infection. Thrombotic and as mechanical complication of catheter-related bloodstream infections has a significant effect on morbidity, mortality, and health care costs. Intravascular catheter-related infections are commonly caused by Staphylococcus epidermidis, Staphylococcus aureus, Streptococcus candida species, and gram-negative organisms. Multi-organ dysfunctions or failure. The organ most often injured by sepsis and inflammation are the lungs, kidneys, cardiovascular systems, and the central nervous system. As we previously learned about it, The common organs which are affected are kidney, cardiovascular system, lungs, and nervous system. The most common of these syndromes is acute respiratory distress syndrome (ARDS), which is associated with 40% of the cases of severe sepsis. Okay, septic shock, an infectious process that induces a severe or protracted SIRS can result in a septic shock. Sepsis is associated with hypotension, systolic blood pressure is less than 90 mmHg, mean arterial pressure is less than 60 mmHg, adequate fluid resuscitation. Septic shock is usually characterized by inadequate tissue perfusion and widespread causes of hypertension and septic shock. Hypertension is due to decreased circulating intravascular volume resulting from a diffuse capillary leak, myocardial depression, and systemic venodilatation. Okay, hemodynamic subsets. Hemodynamic subsets. The circulation in patients with septic shock is often described as either hyperdynamic or hypodynamic. Hyperdynamic septic shock is characterized by normal or elevated cardiac output and profoundly reduced systemic vascular resistance. Mixed venous oxygen saturation is characteristically increased in the absence of hypotension, hypoxemia, and likely refers the increased cardiac output and the cellular metabolic defects in oxygen utilization. Okay. Hypodynamic shock often occurs early in the course of septic shock. It is more likely to be seen in severely hypovolemic patients and in those underlying cardiac disease. Myocardial defection is permanent. Mixed venous oxygen saturation reduced in these patients. Pulmonary hypertension is often prominent. Elevation of pulmonary vascular resistance, the increase in pulmonary vascular resistance may contribute to the right ventricular dysfunction. Okay. Clinical manifestations. Septic shock classically present with an abrupt onset of chills, fever, nausea, and often vomiting. Decreased mental status, tachypnea, and hypotension. And tachycardia, the patient may appear flushed and feel warm, hyperdynamic, or pale with cool and often cyanotic extremities, in case hypodynamic. Clinical manifestations where I want to tell you something extra. Like leukocytosis with the left ward shift to premature cell forms is typical, but leukopenia can be seen with overwhelming sepsis and is an ominous sign. Progressive metabolic acidosis, usually lactic acidosis, is typically partially compensated by a component respiratory alkalosis. Elevated lactate levels reflect both increased production resulting from poor tissue perfusion and the decreased uptake by the liver and kidneys. Oliguria due to the combination of hypovolemia, hypertension, and a systemic inflammatory insult with the often progress to kidney failure. So, elevation in serum administration and bilirubin are due to hepatic dysfunctions. Insulin resistance is uniformly present and produce hyperglycemia. Thrombocytopenia is common, is often an early sign of sepsis. A laboratory evidence of disseminated intravascular coagulation is often present but rarely associated with the bleeding diathesis. Stress, ulceration of gastric mucosa is common. Respiratory and kidney failure are the leading cause of death in the septic patients. Okay, so monitoring in ICU, how do you monitor the cases of ARDS? Non-invasive monitoring include basic monitoring. Pulse rate is increased, volume is low, blood pressure is low. As for blood pressure is due to the following causes like myocardial depression, vasodilatation, leak capillaries, decreased circulating volume. Respiratory systems are metabolic acidosis leading to hyperventilation, increase in rate and depth. Pulse pressure and temperature. Pulse pressure usually narrow before decrease in the BP due to slight increase in the diastolic pressure due to vasospasm and due to decrease in systolic pressure due to the decrease in cardiac output. Temperature, patients may appear flushed and feel warm in case hypodynamic, and pale and cold and cyanotic extremities in case hypodynamic. However, the SpO2 low, especially when diffusion capacity defect is occur. PtCO2, this measures the concentration of CO2 in exhaled gases, which reflects the intra-alveolar concentration of CO2 at end of the expiration at 4 to 5 mg less than PaCO2. EOP patient should not catheterize to measure urine output every 30 to 60 minutes. Urine output should be at least 25 to 30 milliliter per hour or 0.5 to 1 milligram per kg per hour. In visual monitoring, central venous pressure. By putting the catheter in major veins by the Esplandier technique, this is connected to water manometer or transducer. In septic shock, there will be a decrease in circulating volume, leading to decrease in CVP, pulmonary artery pressure, PW. Direct blood pressure, arterial blood gas analysis essential because in septic shock there is a big changes in gas condension, means low PO2 and high PaCO2, with increase in pH of the blood due to metabolic changes and then to respiratory causes when ARDS occurs. Management of severe shock and septic shock. So initial excitation. Following goals have been established for the first 6 hours of management for patients with severe sepsis and septic shock. Central venous pressure is daily about 8 to 12 mmHg. Mean arterial pressure is equal to 65 mmHg. Urine output is equal to 0.5 ml per kilogram per hour. SVO2 or SCVO2 is equal to 70%. When SVO2 and SCVO2 are the oxymolecular saturation in central venous pressure in superior vena cava, blood and mixed venous pulmonary artery. In ventricular dependent patients, higher target central venous pressure and between 12 to 15 mmHg is recommended. Treatment control of eradication of the infections, maintenance of adequate perfusion, target organ treatment and executive therapy. In case central eradication of the patients by appropriate and timely interventions, antibiotics, drainage of abscess, debridement of necrotic tissue and removal of infected foreign bodies. So what about treatment? Control of eradication of the infections, management, maintenance by adequate perfusion, target organ treatment and adjunctive therapy. In case eradication of infections by appropriate and timely interventions, antibiotics, drainage of the abscess, debridement of necrotic tissues and removal of the infected foreign bodies. In case adequate perfusion, maintenance with intravenous fluid and inotropic and vasopressor agents. In case target organ damage of complications such as ARDS, kidney failure, gastrointestinal bleeding and DIC and adjunctive therapy. What is the choice of antibiotics? Antibiotics treatment usually be initiated before pathogens are identified, but only after adequate cultures are obtained, blood, urine, wounds and sputum. The combination of a penicillin beta-lactamase inhibitor or third generation cephalosporins with an aminoglycoside is used. Vancomycin is added if intravascular catheter-related infection is suspected. Clindamycin or metronidazole may be given in neutropenic patients if a rectal abscess is suspected. Antiviral therapy should be considered in septic patients who are more than 1 month post-bone marrow or solid organ transplantation. Empiric antimicrobial therapy. In terms of antibiotics are recommended starting during within hours of recognition of severe sepsis or septic shock. Before starting antibiotics, at least 2 sets of blood cultures should be obtained. Remember that the yield from blood cultures is directly dependent on the volumes of blood culture. For an optimal yield, both from blood cultures, a volume of 20 to 30 ml of blood should be withdrawn from each manufacture site. Circulatory support. Tissue oxygens and perfusions are supported with oxygen, intravenous fluid and drops and vasopressors. Central venous pressure is maintained at greater than 8 mmHg and central venous oxygen saturation is maintained at greater than more than 70%. Packed red blood cells transfusions are given keep hemoglobin levels greater than 8 gram per day, especially with central venous pressure and central venous oxygen saturations are below targets. Fill the tank, central venous pressure, insert central venous catheter, internal jugular or subclavian vein. Measure the central venous pressure. Goal is CUP is equal to 8 to 12 millimeter Hg. So this is to keep CUP at 12 millimeter Hg. If it is less than 80 millimeter Hg, 500 ns at 30 minutes until 8 is there. If 8 to 12 millimeter Hg, ns 100 ml per hour we are giving. If more than 12 millimeter Hg, whole IV fluids. Intubate patients may need CUP of 15 millimeter Hg. Vasopressor therapy is generally initiated by if hypertension means mean arterial pressure is less than 65 mmHg or elevated blood lactate levels persist following administration of intravenous fluids. Suspected choice are norepinephrine or dopamine. Other positive inotropes, including dobutamine, are indicated only when the SpO2 falls below 70%, despite fluids and vasopressor therapy. Patients with persistent elevation of the lactate or persistent low central venous pressure oxygenation can be treated by 200 to 3 mg per deciliter of hydrocortisone. About dopamine, usual dose ranges from 5 to 20 mg per kg per minute, and norepinephrine effective dose range in sepsis is 0.2 to 1.3 mg per kg per minute, about 1 to 10 mg per minute for 70 kg patients. Blood glucose should be controlled with a target value of less than 180 mg per dl. In patients with hypertension that is effective to norepinephrine plus dopamine or dobutamine, vasopressors may be administered to improve the blood pressure. Severe acidosis may decrease the efficacy of inotropics and should therefore generally be corrected when pH is more than 7.2 with bicarbonate. Supportive therapy, ventilator support. The goal of mechanical ventilation include improvement in gas exchange, reduction in work of breathing, avoiding oxygen toxicity, minimize high airway pressure, avoiding further lung damage and allowing the injured lung to heal. A lung protective and pressure limited ventilation strategy has been shown to improve survival rates in the lower state bedroom. Current recommendations are to use a tidal volume of 5 to 8 mg per kg, a longer inspiratory time, and not to exceed transpulmonary pressure over 30 centimeters. Permissive hypocapnia may ensue but is tolerated, which may occur with the use of laser tidal volume. The use of PEEP may reduce or prevent the ventilator-induced lung injury. The use of the prone position and nitric oxide may provide the beneficial in the short term, and the interventions have been shown to improve the survival rates. Patients with sepsis initially are observed in the wards or in the emergency department. After initial attempts at stabilization, transfer the patient to ICU for invasive monitoring and support. Ventilator support in invasive catheter further worsen the risk of infections. Avoiding the use of catheters and remove them as soon as possible may prevent the severe sepsis. Ventilator supports and invasive catheters further worsen the risk of infections in the patients. Avoiding the use of catheters and removing them as soon as possible may prevent the severe sepsis. What is the adjunctive therapy? Like steroids, means hydrocortisone, if hypertension poorly responsive to fluid and vasopressors. If adrenaline is insufficient, do not use corticosteroid, then stimulants test and immunoglobulin therapy. Complication of sepsis. Acute lung injury leads to ARDS is a major complication of patients with severe sepsis and septic shock. Incidence of ARDS is approximately 10% of the patients with septic shock. Acute renal failure occurs in 40 to 50% of the patients with septic shock. Acute renal failure complicates therapy and worsens the overall outcome. DAC occurs in 50% of the patients with septic shock, and death can occur in 40 to 50% of patients with septic shock. Thank you for listening. Thank you.